I think that the main thing that I end up telling every single family that has a loved one with addiction is that the family member themselves needs to get support. This isn't to villainize that there is something wrong with the family. It's to say that this is hard.
You're listening to Conscious Mind.
Hello, everyone. Welcome back to the show. Today, I'm joined by Dr. Amy Swift. She is our Deputy Chief Medical Officer here at Silver Hill and is also board certified in addiction psychiatry. So I think we're going to change up the format a little bit today and do something different and kind of focus in on addiction medicine, addiction psychiatry, and really pick Amy's brain on the subject. Addiction is a condition that Silver Hill has treated for decades and decades. At one point in time, the hospital was predominantly an addiction treatment center. We've always had, the psychiatric hospital, but that we were very, very big in this area, and we remain very much focused on addiction as well as mental health. And many of our patients that come here are dually diagnosed, so they have both mental health and substance use disorders. So welcome, Dr. Swift.
Thank you so much. It's a pleasure to be here.
So let's start with kind of a free, open thought exercise. So when I think about the show, I think about, what do people want to know about just the general population? Lots of doctors and clinicians and others may listen to the show and they have an idea of what addiction is and how it all works together. If you were, let's say, standing on a stage with a crowd of thousands of people and you had 5 minutes to share some really interesting insights about addiction, what would you share?
So it's a great question because I find myself wanting to tell more people about addiction so that it's less stigmatizing to everyone and that we could talk freely about it at dinner or at cocktail parties, that it's something that people aren't shameful about. And there are two things that I would really say about addiction. Number one is the biggest question: what is addiction? And the way I answer it is by describing what drives addiction, because we could describe addictive behaviors and a pattern of behavior, but many people won't say that that applies to them. It won't resonate with them. So the way that I describe addiction is that it is somebody that has engaged in a pattern of use such that they no longer are able to break the cycle. And it's not that they are seeking the high anymore. Patients that overuse different substances, drugs, alcohol, cannabis, are not trying to achieve this magical state of joyfulness. They're really trying to stop that negative emotional state that comes after they use. So they're trying to come in from the cold. They aren't seeking this exhilarating experience. They really are in such distress that they can't get off the wheel and they can't stop using because that negative emotional state that follows the use is so distressing to them. So that's the first thing that I really try and explain to loved ones of patients that are struggling with addiction, or just to talk with somebody who's asking me, am I addicted to this? I'll ask them more about what happens after you use cocaine, after you drink a lot at night. What's the next day feel like? And when they describe it to me, I'll ask them, what do you do to relieve that? And if they really don't have other coping mechanisms to relieve that distress other than using the substance again, then we'll start to talk about why that might be an addictive disorder. The other thing that I talk about is with the legalization of cannabis, that there are two types of people that use cannabis: people that use it very recreationally and have absolutely no implications from it, no consequences. And then there are people that use it and they change the chemistry in their brain in such a way that it leads them to a psychotic or paranoid state. Many people can describe some paranoia when they smoke pot, but there are a subset of people that when they smoke it, it really leaves this dent on their brain such that that paranoia remains even after they stop smoking. And because cannabis has been, legalized many places, people think that it's safe. It's very much like alcohol. And so it's really important for me as an addiction psychiatrist to educate the public about the potential dangers of cannabis for some people.
That's fascinating. So for young people, let's say it's their first, second, third time trying it. Is it possible that if they stop then that they won't be affected in the long run? Like, is it chronic use, or can this kind of shift happen with just a few times of using where like it kind of opens up some of that psychotic thought pattern? Or
there are some people, if they have a predisposition in their family, if they are somebody that has a person with a psychotic disorder in their family, they could smoke it once and it could really accelerate what may have already been in their history, destined to happen. But other people could smoke it once, twice, notice they get a little bit paranoid, and if they stop then, it never comes back. It goes back down under the surface, and we never kind of uncover it again. The thing that I will say is that there are a couple of predictors to whether or not it will have an impact. One, the younger you use it, the more chance that it could have an impact. And two, the more, as you're saying, densely you use it. If somebody is chronically using kind of all day long, ignoring the result of it, the paranoia, and continuing to kind of push through, then the chances that they may end up with a psychotic disorder or a bipolar disorder later in life are higher.
So what do you say to the people who swear by, the fact in their minds that smoking weed or taking edibles or any of these things is like medicine for them? It makes them better. It is, the only medication, quote unquote, medication that's worked for them. And they report that they're functioning much better on it than off it. What would you say to that?
The first thing that I draw attention to is how they ended up talking to an addiction psychiatrist. So if it were at a dinner party or, a cocktail party or something, and they just happen to be in my path, fine, I'll kind of discount that. But if we're meeting in some sort of clinical setting, I'll say, I understand the importance you feel cannabis plays in your life. And tell me what brought you to see me today. Because the idea that there is some relief to whatever symptom they were experiencing and they were seeking cannabis for is going to be something they're going to hold on to tight. So I can't discredit it immediately. They may say, it really helps my anxiety. So my answer would be, you've got no anxiety. I've never heard somebody say, you're right, none. They always say, no, I do. But every time I smoke, it's fine. And then I'll say, it goes away for the rest of the day. You never have to smoke again. And they'll say, no. I smoke before bed because it comes back. And so I'll say, days when you can't smoke, your anxiety is wild, you can't control it, you don't function. They'll say, no, there's days that I don't smoke and it's fine. And so then I'll say, so help me understand how the cannabis is the only thing relieving your anxiety and that you need that.
Right.
And I'll hear more from them.
Right. And so if we compare and contrast with real, and I say real because it's all relative, right? If we compare and contrast with medication, psychiatric medication, and anxiety, if we use that example. So you can either use marijuana in the way that you've been using it to control your anxiety, and these are the pros and cons. How would you make an argument for something different that may be more helpful?
The way that I recommend people manage anxiety is that they do it by lowering the baseline anxiety from the beginning. So they take away or disengage the idea of, I feel something, I take something, because that is a tough place, a corner to be backed into, honestly. If you have overwhelming anxiety and your only coping mechanism is to have something external remove it, then if you don't have that external thing, you feel panicked. You don't have any chance of relief. So what I explain to people is that cannabis is very much like taking a PRN or an as-needed medication. You feel something, it gets to an escalating level, and you have something external remove it from you. But it doesn't take it away. It doesn't take away the cause. It doesn't change the brain chemistry. It just removes the distress for that moment. It distracts. So what I tell people is that I recommend taking one of our FDA-approved medications that can be taken daily that is not taken when your anxiety is high. But the idea is that as you take it daily, it changes the brain chemistry such that the anxiety that was living at a 7, that when it got to a 9 was unbearable and you took something, now lives at a 4, a 5. When it escalates, it only goes to that 7. Well, guess what? You were living at that 7 before, and that was tolerable. So even if it got to a 7, you're okay. So I can't change the circumstances. I can't change your life, the things that may happen to you. But what I'm doing by giving you a daily medication to change the way that your receptors are firing is I'm giving you a jacket to go stand out in the cold. The 30 degrees might still be there, but now you're wearing a winter coat, so it's more tolerable. The biggest struggle with people that seek other things to relieve anxiety, benzodiazepines or cannabis, is that there may be some inflection point where those aren't available anymore. So for example, with benzodiazepines, if you age into, a realm of where we wouldn't be comfortable prescribing it, all of a sudden that tool that you were using is no longer in your toolbox. If for cannabis you have a psychotic episode, all of a sudden that tool really isn't in your toolbox. So if you were using it to manage anxiety, but now it's promoting a pro-psychotic state, you're stuck. So we really should consider other viable options that could be used throughout your entire life to manage anxiety.
Let's talk about benzodiazepines, because I think it's an important conversation, I think, for people that are not doctors, clinicians, have a lot of education in the area. Often people with anxiety take benzodiazepines daily, as needed, as you say, or they're on some sort of schedule where they take it multiple times a day to manage their anxiety. And people become physically very much dependent on it. Can you talk a little bit about, educate a little bit about the danger of that, just in the sense that if you were to stop taking it too quickly or, taper too fast, what are the consequences of that? Because I'm not sure everyone who's prescribed actually knows that.
So I think that it is the biggest thing that, as an addiction psychiatrist, one of my biggest missions in my career has been to educate other prescribers on how to deliver that information to patients, because you're starting them on a drug that if they were to stop it abruptly, they could have a seizure and they can die. And a patient needs to understand that before accepting that medication. So one of the things that I learned early in my career is that when we tell patients, you could take this as needed up to twice a day, I'm thinking they're going to say, all right, if I need it, I'll take it. There may be 1-2 bad days a month where I'll take it twice a day. The patient's hearing, oh, good, I can use this twice a day. So they take it all, twice a day, every day. And when you thought you'd given them this low-risk medication to use to kind of as an emergency brake if the anxiety was wild, now you've given them this medication where they can develop tolerance, which means that the dose that achieved symptom relief will no longer achieve symptom relief after a period of time. And they've developed dependence, which means that if they stopped the prescription immediately, that they could go into withdrawal. And benzodiazepine withdrawal, as you stated, can be deadly. You can have seizures, and it can lead to what's called status epilepticus, where you have a seizure for a prolonged period of time, which can result in death. I highly doubt if you told somebody this without describing the medication, they'd want to take it. If somebody said to me, here, I'm going to give you this med for this purpose, not telling me what it was, and say these are the risk factors, I'd be like, why would you do that?
Right.
This is concerning.
Right.
There are great uses for benzodiazepines. People that have fears of flying,
yes.
Amazing. Give them they're
right,
not flying.
Because it's once in a blue moon, you're taking it, helps you relax. It's very effective
right.
in the short term, right? But
right.
you get into the reinforcement cycle and the whole thing. Yeah.
Right. We don't have flight attendants that come to us looking for benzodiazepines for flights. We don't have pilots coming to us looking for benzodiazepines for flights. Because if it's an everyday experience, then we're defeating the purpose.
That's a really interesting way of looking at it. And just for education purposes, we've been talking about benzodiazepines, but that's like Ativan, Klonopin, Xanax.
Xanax is the biggest offender in my mind because it has street potential and it's very ubiquitous in our society. But it is a medication that I honestly don't think has a clinical benefit because it's so short acting. It comes on really fast, but it comes off really fast. And we have patients described to us what's called rebound anxiety, where they took it to remove an anxious state that only becomes amplified when that medication wears off. So I don't think that it's something that we ever really need to use. I think Ativan can serve that same purpose. Ativan works quite quickly as well, and it has a slower kind of come-off effect. So I feel like for the episodes of panic attack, Ativan's completely appropriate. For those people that need it to get on that flight, to take that step, that's completely appropriate. Klonopin's maybe a little bit better if the flight is a bit longer because Klonopin comes on a little bit. It takes a little longer for it to feel the effect, but then it stays on a little bit longer and comes off slower. There are, definitely really appropriate uses for benzodiazepines, and it's one of the most prescribed medications by primary care physicians for kind of short descriptions of anxious situations that patients give them in passing.
It's a lot. And for the average person to be able to follow like the details of this and the freeness with which it's prescribed. I know it's tightened up a lot in the last several years. Like, it's not as easy to prescribe anymore, and there's some controls in place, but it's still everywhere, right? Everybody knows about it by brand name. And it leads people down. It can lead people down a really difficult path to get back from.
Right. And what you talk about is the physical dependence, but the psychological dependence is actually more troublesome. Patients can't understand why we aren't recommending to continue a medication that they see as providing relief to a distressing state. This is the only thing that helped me, doc. How dare you take this from me? Why are you doing this to me? And one of the things that we see with chronic benzodiazepine use is very much like what we see with chronic opiates. There's this concept when you take opiates for a while that you have this syndrome called hyperalgesia, which means that you actually experience low levels of pain as significantly worse than what would objectively it would lead to. So like if you're taking a bunch of opiates and you scratch your leg, it may feel like a 10 out of 10 pain, when in reality it probably is like a 4.
Right, because your body keeps a score. Your body learns.
Exactly.
Like, it forgets how to manage its own pain.
Right. So the same thing happens with benzodiazepines. When you've been taking them for a while and you have this really distressing event, you have no coping strategy. You've got no distress tolerance. So the thing that might be a little agitating all of a sudden sends you into a full-blown panic. And now if you're already at a level of benzodiazepines where you're teetering on whether or not you could take more, you got no options. So you have no internal coping skills because you've been distracted from using them. You're feeling this amplified sense of panic, and you put yourself at risk for respiratory depression, which is what high doses of benzodiazepines can lead to. So you're really stuck. And that's the thing that we as addiction psychiatrists end up seeing is these patients that had been on what started as a low dose benzodiazepine, they no longer achieve symptom relief. Primary care provider typically escalates the dose. Then they're on this absurd dose and they come to us and they're being told that their prescriber won't prescribe anymore. Help me. And so we have to figure out how to safely get them to a better dose and manage the symptom that this was supposed to be managing, which is now amplified by the fact that they have no coping and they're feeling these exaggerated responses.
While we're on the subject of controversial medications to prescribe, what about stimulants?
So stimulants are tricky too. These are another one of the really difficult medications for us. I think stimulants, again, have a great use and purpose. For patients that struggle with ADHD, they are life-saving. These patients really can't feel a good sense of self-worth when they can't accomplish their tasks. But stimulants, again, have to be used in an appropriate way for an appropriate time. For example, stimulants do not need to be 7 days a week unless you work 7 days a week. There is an absolutely justified purpose for doing stimulant holidays. People have poor sleep on stimulants. People have poor appetite on stimulants. These are basic human needs. So if we are doing that 24/7, your body's going to take a toll. The other thing is that there are, again, a subset of population of patients that are not appropriate for stimulant prescriptions. Patients that have a cocaine use disorder. There are some studies that support using high-dose stimulants to treat the cocaine use disorder. However, this is done in a controlled setting, and it just is not generalizable to the population. And addictive behaviors tend to translate. So for a population like that that's struggling with ADHD, but also a stimulant or a cocaine use disorder, I would recommend a non-stimulant option for ADHDs.
Can I ask a question that I've never understood? And this is one of those things that people say, and I don't know if it's backed scientifically, is like stimulants work different in different people. Like for some people, it behaves like speed, and for some people, it calms them down. So what's going on there?
That is true. If they do have really, truly ADHD, it will calm them down. So you can see it mostly in kids.
Why is it different?
Because they have a different way that their brain's firing. Their brain is firing in a way that the way that the stimulant releases dopamine in their brain improves their functioning. Anyone, and this is what I tell people all the time, because they're like, oh, I was much better focused on a stimulant. I'm like, yeah, everybody is. Everybody is. It's just whether or not you're better focused and you're calmer, or you're better focused and you didn't need it. And this is just like kind of doping in sports, right? Like you're accelerating.
Performance enhancing drug. Yeah.
You're accelerating your performance. But for people that have a stimulant use disorder or cocaine use disorder, or people that are psychotic or manic, stimulants will promote psychosis and they will promote mania in people that have that diathesis, that underlying predisposition. We really can't reasonably prescribe them to people, even if they have ADHD, that have those potential diagnoses. It just doesn't.
So if I were a patient and I came to you and I said, I think I have ADD or ADHD and I really, I've never tried a stimulant. I think it could really help me. And you prescribe it to me and I come back and say, wow, I have more energy than I've ever had. I'm super focused. I'm so productive. Would that be kind of evidence to you that I don't in fact have ADD or ADHD?
It would, if you came back and looked manic, we would stop it immediately.
Okay.
Because it meant that there was something lying in that brain that we just uncovered.
Mm-hmm.
It doesn't mean that we couldn't find something to help with focus. And this is what I often struggle with really, really intelligent bipolar patients. They come to me and they say, I needed this stimulant. I was so disorganized, I couldn't do anything. But what it was underlying mania, hypomania. So they couldn't focus because their brain was going 100 miles per hour and they couldn't rein it in. So although they want it to be ADHD, because that's less stigmatizing, it's not. It's bipolar disorder. And I can quiet and I can help you focus, but it's not going to be with the stimulant option. It's going to be with a mood stabilizer or a second-gen antipsychotic, something that will treat the bipolar disorder, and the result will be that you're now able to focus.
Right, right. So I want to switch gears and talk about families and addiction and how, obviously when you have someone who's struggling in the family, the impact that it can have. And you've been doing this a long time and you've worked with many, many families and you've probably seen every shape and form of what this can look like. What is your advice for families that have a child or a spouse or someone who's really in the throes of addiction?
I think that the main thing that I end up telling every single family that has a loved one with addiction is that the family member themselves needs to get support. This isn't to villainize that there is something wrong with the family. It's to say that this is hard. Watching your loved one make a choice that could destroy their life is absolutely gut-wrenching to see. But the idea that addiction is a brain disease, this patient, as I started with, isn't choosing to use cocaine, isn't choosing to use alcohol in a destructive way. They're not choosing to, snort heroin. There is something that kind of clicked in their brain, potentially the first time they chose it, or after a period or a pattern of use, that they're now stuck. And if we, as the family member of one with addiction, start to understand a little bit more about that, we can find the empathy for how we can appropriately, with boundaries, support our loved one. So I'm not saying that we have to enable them, provide housing for them. This isn't a needle exchange program, but this is to say, you want to be, I've said this to patients with younger people that struggle with addiction, you want to be mom. You need to start figuring out how you can be mom. And the way to do that is to really, in your own work, in therapy, in Al-Anon, different organizations that really start to talk about hey, I get that you want to save them. You can't be their savior. We're not the police, but you get to be mom. So figure out what that looks like for your situation, which boundaries allow that, and where you need to just say, this is dangerous and I can't do this anymore. I had this conversation with a patient earlier where if you feel unsafe, you can't continue to do what you're doing. And there does, with addiction, unfortunately, there is this line between when you have to say this is a legal issue. And particularly with opiate use disorder, it disrupts patients' executive functioning such that they do make some really dangerous choices. It's why moms overdose with their babies in the back. It really disrupts the brain's ability to make a reasoned decision. So there could be legal implications of patients that struggle.
So I find anecdotally, and I don't really have any evidence to back this or support it scientifically, but I do think there's an avoidance for some family members to get their own help because they're afraid they're going to find out that they somehow caused this or that they are, it's their fault that their child is addicted, whether it runs in their family or it's something, did I make the wrong decisions when I was raising my baby? Did I not hold them long? And I mean, all of these questions that can come, especially into a parent's mind. So what do you say to those people that are just reluctant to open that door? Because we all know on our side of the world that 9 times out of 10, they didn't cause this. This is not something that you can't look at it that way.
And I tell them we also can't change the past. So there isn't any utility in villainizing ourselves about how we've contributed to somebody's outcome. And the idea that we have to stay in the here and now, figure out how to weather this storm, but not look for causes. If we knew what caused addiction, we'd prevent it.
Right.
But we don't. It's the same thing with suicide. We're not good at preventing suicide.
It'd be on every commercial on TV. Here's what you need to do to prevent suicide. Here's what you need to do to prevent addiction.
Exactly. And we'd all do it because none of us are seeking this.
Right.
It's just not, it's not an equation that we can look at and figure out the pieces and then remove the one piece. And so I tell them that they really, although it is a human condition to kind of try and go back and figure out the contributing factors, it's not a good dedicated use of your energy. Figure out how to move forward, and that I can support you in, because I can't change it when I wasn't there, but I can help support you in how to navigate this going forward.
Right. Stay present focused. And what can we do now? What can we do moving forward? So I'm going to ask you a very typical conscious mind type question. In terms of the future of addiction psychiatry. So if we project ourselves, 20, 30 years from now, where do you see the field going and what gives you hope?
So I think the fact that for all the things that kind of the millennial set did for us, that good or bad, the idea that they have adopted this non-stigmatized approach to addiction has been kind of great for us. There are a lot of people that choose sobriety not because they had to, but because it has been this trend in the pop culture. And that, hopefully, we can take the play on that and accelerate it and disseminate it to the people that really do need to choose sobriety. So I do hope that going forward, we can have more free conversations about what it's like to have problematic substance or alcohol use. The thing that had kind of plagued us 50 years ago was that nobody really talked about it when everybody knew who it was, but nobody would ever say, oh yeah, they get way too drunk, they're really problematic when they're drunk. Now it's kind of accepted to say that. And I'm hoping 30 years from now, that person feels like, oh wow, I had 2 and I had 10 and that I can't do again. Because I think that it's something that much like, it was hard, probably, I assume, for people 30 years ago who had celiac, they didn't want to tell people they couldn't eat bread. Now everybody doesn't eat bread, and it's okay.
It's become cool not to eat bread.
Yeah. So I'm hoping for the same for some of our really problematic addictive substances.
It's a really interesting way to look at it. I love that. Because it is. I mean, everyone now is gluten-free. It's become, like, acceptable, and people think, whether or not it's true and they need that or not, it's whatever, right?
Right.
So speaking of people that, you would look at and say, okay, I think that person has a problem, whether this was a long time ago or currently, what is your advice for people who have a friend or family member that they think has an addictive disorder? And do you suggest they talk to them about it? How do you approach someone who may still be very defended about what's going on?
It's a great question because it's a question I get most in my personal life. People will come to me and say, don't tell anyone this, but, and then ask me the question and say, what do I do? So the first thing that I tell them is that you can absolutely have this conversation with your friend, family member. Don't do it when they're intoxicated. It's not going to go anywhere. They're not reasonable. So you definitely have to wait till an opportunity where they can have a reasonable discussion about it. And then also just be curious. Say to them, what are your thoughts about your relationship with alcohol? Tell me, do you have any concerns about how much pot you're smoking? And if they say absolutely not, say, okay, we can agree that we're going to disagree right now because I have some concerns, but can we keep the conversation going? I don't want to ever feel like you feel like I'm stigmatizing this, but I want you to know that if ever you share or see where my concerns are coming from, that you can come to me. And then the second that they do, because oftentimes they do, you say, okay, let's go talk to somebody. You don't have to accept any treatment right now. Let's just go ask the question. Because when they can come into our offices, then we take the non-judgmental approach. And I'll say, I started with a patient on the inpatient unit that came in for detox. And initially the patient said to me, I have no problem with alcohol. I am not stopping drinking this, that, and the other. By the end of his stay on our residential program, he was asking me for the naltrexone that I'd offered him the day I met him. And I didn't push it the day I met him because he said he wasn't ready. But I planted the seed. And much like, when we plant seeds, we don't expect them to grow into a tree right away. We water them. We give them sunlight. We do all the nurturing things. And then someday we're going to see that tree. So it's very much like that with a loved one or a friend with addiction. Plant the seed, nurture it, water it, sunlight it.
Right. Don't judge.
Exactly. Wait for that tree to grow.
Because you want that person to come to you. You don't want to alienate them. You don't want to say, okay, well, I don't want to hang out with you. I don't want to see you. I mean, unless it becomes a really
Exactly.
destructive.
And that's where I tell people, like, set a boundary. If somebody is very drunk and dangerous around you, don't get drunk with them again. Don't put yourself in that situation. And I say this to parents all the time. They'll say, oh, but like I want them to be able to have wine with dinner with us. I say, but was that an enjoyable experience? And they'll say no. I said, so don't choose that opportunity again. Find a different bonding experience that doesn't involve wine at dinner.
Right. Or offer to take them to a meeting if you have an opportunity. I think there's a lot of ways that you can put out the olive branch of trying to help someone.
Showing someone that you're not afraid of the stigma of being associated with somebody with addiction is just as empowering as telling them that you're there for them. Saying, I don't care if I'm seen with you at an AA meeting. I don't need to share that I'm not actually addicted to alcohol. I could just sit with you.
Yep.
That's fine.
Simple as that. So, any last thoughts on this subject that you would like our listeners to know?
I mean, I think that the thing that I would love for people to know is that you can always come and ask questions. It does not, there's no harm, no foul of saying, hey, I want to talk to somebody. I want to just describe what's happening and just get some feedback.
Right. If you're not sure if there is something wrong.
Right. Maybe the answer is, listen, like right now there's not. I said this to a 25-year-old patient that she was saying how much she uses cocaine. And I said, listen, I know you don't want to stop, and I'm not here to prescribe something to you, but I want you to pay attention because although it seems as though all your peers are doing it right now, look in 5 years. If your pattern of use is different than those around you, then come back and talk to me.
Right.
But I can't tell her that it's too much. She thinks it, wasn't problematic, wasn't disruptive of her life. That's okay. Just keep the conversation going and check in kind of if you are in line with social norms. And when you find, because what patients often find is that their trajectory continues up and other people stabilizes out or goes down, which is characteristic of substance use everywhere. All of us would be classified, that drank in college would be classified as binge drinkers because many of us didn't drink during the week and then we drank more on the weekend, which is the definition of binge drinking. But we didn't keep doing that. We're not doing that in our 30s, 40s, 50s. So that's what I would say is just come in and have the conversation so that you have the touch point. Should it ever really escalate to a problem where you want help, you already know who to call.
Dr. Swift, thank you so much for being here with us today. I feel like I learned a ton from you in this time that we had together, and thank you for all that you do for your patients and for the hospital. Thanks again.
Of course.
You've been listening to Conscious Mind on Silver Hill Radio.
No, don't worry. I can cut all this stuff out.
Okay.